Hello and welcome to week 4. Wow, time is flying by and we are right at the middle of our time together in this course, learning how to report inpatient surgical procedures using ICD-10 PCS. And I thought it would be a good time for us to review the approaches, also known as the way the physician gets to the body part that needs to be cared for or treated. This does tend to trip people up, trip coders up. So let's have a little review, okay? All right, so just to remind you, the approach is identified in the 5th character position. So as you have learned and been doing, in the 1st character position, you have the section identified. Med surg is a 0, obstetrics is a 1, for example. Okay, the next character, the 2nd character, is the body system. The whole system. And you will note that sometimes it is not a complete body system as you learned in anatomy and physiology, because as you can see here on our example table, this body system is skin and breast. But when you learned about a body system that would be related to this, skin is part of the integumentary system, and the breasts, the mammary glands, are part of the female reproductive system. So while what you learned in your anatomy and physiology is foundational, you also need to read carefully and understand the way ICD-10 PCS does it. Okay, because they have little twists and things on, okay. All right, next is the root operation or the operation term, and that is going to describe the verb. Okay, that's the action word. What exactly are they doing? Is it an insertion? Is it an excision or a resection? Is it a bypass? This is the action word or the verb as to what specifically the procedure is all about, okay? The 4th character will identify this specific anatomical site. So you can see here on our example table that you have right breast, left breast, bilateral, the nipple as a very specific anatomical site upon which this procedure is being performed. So remember, the 2nd character, the body system, is the overall body system, but the 4th character, body part, is the very, very specific anatomical site that is being cared for, that is being attended to in this procedure. The 5th character is going to identify the approach, and that's what we're going to review today. And that is, how does the physician get from outside the body to the specific anatomical site, which we just identified? All right. The 6th character is going to identify the device. Now you remember that in PCS, device will only identify something that is placed into the patient and will stay there after the procedure is over. So you have to be very particular and careful with that. Okay, and then the 7th character is the qualifier, which is kind of the miscellaneous category where they can throw in any particular details that are necessary for the complete picture that this 7-character code is going to paint. Okay. All right. So today, as I said, we're going to go ahead and review the different approaches, because this is a very, very important part. Well, they're all important, right? But it's a very important part of the code. Excuse me. Excuse me. All right. So the approach is going to explain how the physician got from outside the body to the specific anatomical site. And what's great about PCS, it's like this huge multiple choice question, right? Because each time your answer is limited to what's on that particular row for that body part in that character. Only what's there are your only choices. So you might be reading through the op notes and say, okay, I know what approach this was. And then you get to the table in PCS and what you had in your head is not amongst the choices. So then you have to go back to the op notes and reevaluate. What are you reading? Maybe there's a different row with that anatomical site. We don't know, but that is kind of like your stop sign to go back and reevaluate. Okay. All right. So the very first one is the live transcription.
It's because I'm hearing impaired.
I had no idea. Okay. I know about 200 words in sign language, if that helps you, but I'm not sure I know medical terminology in sign language, so I don't want to confuse you.
You're not. I have
Okay.
hearing aids. I have hearing aids. It just helps.
Okay. Well, great. You know what? I want to thank you because I didn't even know that was available.
Yeah.
See, you learn something new every day.
Yes,
Teachers teach students, students teach teachers. I love it.
Yeah.
Okay, who can see this transcript? Yes, I want everybody to see this. But you're not giving me.
It shows at the
Okay.
bottom on my end.
Okay. Can you see it now?
Yes, I can see it.
Okay. All right. So let's talk about external. External means directly from the outside. There is not going to be any entry into the body per se. Oh, you spelled it right. Good. Okay. Sorry.
Okay.
I'm so excited about this and I didn't even know. Okay. So external means from the outside. So
Yeah.
if you're going to resection a skin lesion, you're not going into the body, it's just on the outside. All right. Application of a cast on a fractured leg is from the outside, right? There's no going into the body. And that's basically it. There's not going to be any mention of an incision or any kind of entry into the body in any way. Okay. Does that make sense?
That makes perfect sense.
Okay. Next, open. And open, if you will, is the old-fashioned way of doing surgery. That's where they literally cut the body open. They're using a scalpel to make an incision. An incision is one of the key words that you want to look for in the op notes. That's going to tell you that it is an open approach. Okay.
And from a surgical standpoint, they usually announce before they do that open.
Yes, they may announce it, but remember, you are limited to what is in the documentation.
Yes.
So I'm not going to say it never happens, but I have never seen operative reports that say this is an open procedure.
Yeah. They usually just
Use the word
say
tradition, right? They may use the word traditional,
Mhm.
okay? But I don't want you to depend on that because every doctor is different in the way that they are going to describe the procedure itself. So therefore, if the operative notes are required to say, I used a number 7 scalpel and made an 7-centimeter incision. That's going to say, okay, that's an open approach.
Yeah, because of the word incision.
Okay.
Okay.
All right. All right. Next, we're going to talk about percutaneous, and there are two different approaches identified as percutaneous and percutaneous endoscopic. And pretty much percutaneous means, and you remember the layers of the skin. So percutaneous means going into the skin,
Yes.
right? By a puncture or a minor incision. So that means it might be a tiny incision, like 1 inch, all right?
Yeah.
Or it may be where they stick a needle in.
Or they could use a punch box.
A punch biopsy is not percutaneous because it doesn't go deeply enough.
Oh,
It's
okay.
actually considered external.
Oh, good to know.
I know, isn't that weird? It does.
Yeah.
I've had a punch biopsy done, and it sure doesn't feel external, but
No.
yeah, but it is. So percutaneous would be a needle biopsy, for
Okay.
example. Okay. Now, percutaneous endoscopic, you will see more often than not that this is referred to as a laparoscopic
Yeah.
procedure because that is, they cut a tiny hole, and that's the percutaneous, the tiny puncture or incision. And then, but then they take a camera or some other instrument and put it into that incision. All right.
Yeah.
Laparoscopic procedures usually have three incisions. So one is for the camera, one is for the scalpel or the scissors, and then there's a third where that they use to pump gas, actually gas
Oh,
into
yeah.
the body so that it lifts up all of the organs inside so they can pick which one they want to go snip,
Yeah.
whatever.
I unfortunately had that.
Yeah, me too. Okay. Much better than an open procedure though.
Yeah. Yeah.
Right? Okay. So percutaneous means going through the skin, and endoscopic has to do with instrumentation. Endo meaning into, and scopic meaning to see.
Okay.
Okay. All right. Just, a little reminder from medical terminology class. All right. Now we have one via natural or artificial opening. Natural openings, the nose, the mouth, the urethra, the vagina, and the anus.
Okay.
Those are all natural pathways into the inside of the body. No cutting necessary, no incisions, no scalpels. The cave door is wide open.
Yeah.
All right.
Can I ask you a question?
Of course.
How come the ear is not considered a natural opening, considering that it does have a pathway to either the sinuses or the throat or possibly the brain?
Okay, actually, you cannot get into the visceral or the internal organs via the ear.
Okay.
All right.
It can only
First,
be the
and you
ear.
cannot get into the sinuses via the ear.
Okay.
All right,
That
so
makes
you
sense.
go in through the external ear. The first thing you have is a tympanic membrane,
Yes.
right?
Yes.
And then you have the middle ear with the three smallest bones in the entire body. Okay.
Okay.
And then you have the inner ear, which leads to the auditory nervous system that goes right into the brain.
Okay. That's
Okay.
where my hearing's messed up.
Oh, okay.
I
All
have
right.
sensory neuro damage.
Your inner ear?
I was a premature baby, so I was on a ventilator for 3 months. So I have sensory neuro damage.
I gotcha. Okay. Have you thought about a cochlear implant?
No, not yet. I haven't gotten to that level yet. I
Okay.
just got some new hearing aids last week. So I'm still at a threshold where hearing aids are still working, but I still rely on closed captioning because for me, that's how I don't miss out.
Good. Good. Yes, it makes it easier. You use your optical system along with your hearing, and it helps better understanding. And what's
Yes.
interesting is that is true with most people.
Yeah.
But
And
so I'm glad.
seeing is easier for me than hearing because I miss too much if I just relied on my hearing.
Okay. Well, I'm so glad you told me about the closed captioning. Wow. Okay. Yay. All right. So these are your natural openings. The
Okay.
nose, the mouth, the urethra, the vagina, and the anus, because they will all give you access to the visceral part of the body, the internal organs. Okay. No matter where you're going, you can get there.
Okay.
Okay.
That makes sense.
The artificial opening that's referred to here is generally a stoma. Now, a stoma is an artificial opening from the inside of the body to the outside of the body. Most often you will see this after surgery, such as a colostomy stoma, which will happen if any part of the large intestine is removed, or if they're doing a repair and they need to give it a rest. And then that way the small intestine evacuates directly outside the body through the stoma, and until hopefully that's no
I
longer
learned a lot about that because my cousin's a doctor and his wife actually has a colostomy due to Crohn's.
Oh, okay.
Yeah.
Okay, so there you go. See, you know, people come into coding and they say, I have no experience in healthcare. And I go, you're an adult human being. Uh-huh. Yes, you do. Somewhere in your life, you, your loved ones, your parents, your siblings, your friends, your aunt, your uncle, whatever.
I did nursing for a little while when I was young.
Oh, well, there you go. Okay. All right. So that's what you want to look through is, and again, you have to read the language in the op report because the physician is required to say how he got to that body part. Okay. So if you look at a procedure and, we of course have, you may know about bariatric surgery.
Yes, I had a
Okay.
gastric.
Okay. So think about all the different ways that a physician can get to the patient's stomach. Now, obviously, the physician can do an insertion through here, right? So that could be either open with an incision, or it could be laparoscopic, right, with a camera, or the physician can go through the nose or the mouth.
Yeah.
Okay. And actually, that is what an EGD, which stands for esophagogastroduodenoscopy, which is, again, scopy, we mean to look. We go through the esophagus, gastro, the stomach, duoden, and duoden is the duodenal. Okay. So that's why we made you take medical terminology before you came into this class. So you go, oh, esophagogastroduodenoscopy has 4,000 letters in it.
Yeah.
Pick it apart and know what it means, right?
Yeah.
Okay. So that way you can understand, but the physician would have to say, by law, the physician has to say, okay, we're going to, put the endoscope into the patient's mouth and down through the esophagus into the patient's stomach, or maybe it's via the anus and the rectal vault to do a colonoscopy.
Okay.
Okay. So it's really an important combination of what you learned in anatomy and physiology and medical terminology, which is exactly what coding is. Coding requires you to understand all of these things so you can better interpret it into the codes. Okay.
And that's what I'm doing now. I'm actually doing anatomy and physiology coding along with this class and coding one.
Which is diagnosis coding.
Yeah.
I'm sorry.
I
told them that things have to go in a proper order, and I can't do it at the same time. So
yeah, I kind of feel like that, maybe if I had coding 1 and then coding 2, it would have made a little more sense.
And actually, if you would have had A&P first and medical terminology, and then coding 1, and then coding 2.
I did have A&P in medical terminology, but because it's been so long since I took A&P at USC, it's been 20 years.
But that's long enough for it to fall out of your head.
Yeah. And so I didn't do as well as I should in the summer. So that's why I'm doing the A&P for coding now along with 1 and 2.
My heart is with you, but so is my mind. Okay. You remember that anytime you can email me and ask me specific questions, and I will help you better understand. Also, remember what I told you in week 1 is if you don't have a paper medical dictionary, y'all need to get one. Okay. Amazon has one for less than $10. The Merriam-Webster. Okay. So that is priceless. Because I can't tell you how many times, and still after all of these years that I've been doing this, your brain can only hold so much information. And the thing that I love about being a coder that is different than when you were a nurse, okay, is we sit at desks, which means we can have books for reference right with us. So you don't have to say, oh, that's whatever. You can pull that dictionary and look it up and go, oh, now I understand.
And I actually purchased your loose leaf book too.
Oh, excellent. That will also
I just
help.
got it. So I'm trying to employ everything I can.
That's good. And try to help yourself by connecting the dots. And here's what I mean by that is, as you're learning how to code a certain type of diagnosis, then look in the PCS book or even think about the procedures that would be done for that diagnosis. And think in your head is, okay, so if the patient has a certain diagnosis, you might want to look at Medline to see what the procedures are, if there's surgery involved or anything else. And that way you can put the puzzle pieces together for yourself. And I think it will help your thinking and your learning.
And as I've noticed with the case encounters that I have done, and I will agree, I have rushed myself in this course. And when I've looked back at what I missed, it was idiotic errors. it was errors that I looked and went, I knew that. I knew that was where that was. I just learned that, but why did I look
Oh
behind?
yeah. Oh yeah. I call them a oh, right?
And it's
I
just like,
you can't Courtney, I can't stress this enough. Coding cannot be rushed. It takes too much thinking.
it does.
It really does. It takes thinking and analysis of what did the doctor write? What does that mean? And how I need to interpret it into this other language. And this other language may be diagnosis coding. If I'm looking for why did this patient need the care from this doctor, that's going to tell you the diagnosis. Okay. And then I'm going to look at, well, what did the doctor do for the patient or to the patient? That's going to give you your procedure.
Yeah, it is a lot of breaking down. A
It
lot of
right. Yes, it is. So you really need to slow down when you're reading, use your finger. Okay.
okay.
I know this sounds silly, but
Uh-huh.
use your finger. If you're reading on the screen, you want to put your finger, point to each word.
Okay.
Okay. And did you ever watch any of the TV shows, the CSI TV shows? The
Oh
crime.
yeah, yeah. I watched all the what was it? The one with Reed in it.
Oh,
Criminal Minds.
Criminal Minds.
Yeah.
Yes, that's good too. Yes.
Oh
If we only had his memory, that would be
my
something,
goodness.
right?
Yeah.
Spencer Reed. Okay, so you know how when they go into a crime scene and it's dark and
Mhm.
they use those little tiny flashlights?
Uh-huh.
Okay. The reason they do that instead of turning on the lights in the whole room is when you turn on the lights in the whole room, your eye says my responsibility is to see everything, send that information into the brain. Okay. Now your brain is on the other end of rush hour traffic because all of these pictures and words are coming into their brain. It's like, well, I don't know what you're doing.
It's
Okay.
overloading.
Overloaded is exactly the right word. Okay, so instead, we want to use a little tiny flashlight and keep the rest of it dark, if you will. All right. But I'm not telling you to read stuff in the dark. But the same thing happens with the tip of your finger. When you point to a word, all of a sudden, your eye focuses on the tip of your finger and that word and doesn't really see anything else.
Yeah.
So if you look at the screen that's on it, then your brain will say, keep your foundation strong. Now the words are going up into your brain one at a time, and your
Like really
brain has the
consistent.
opportunity to analyze it, understand it, and oh, okay, now I understand.
Yeah.
Okay.
Okay.
All right. So just that, and they let you bring your fingers in with you to the certification exam too. So yeah,
That
they will
helps.
check them to make sure there are no notes on them or anything, but they're allowed. Okay. So the fact is that everybody, including me sometimes, feels a little childish to use their finger to, but whether it's in the textbook, in the loose leaf binder, you know, and you're reading, the fact is in healthcare, there are a lot of words to read. You know, you look at some of, not the ones we give you in your testing because we try to shorten them, but there are some operative reports that you may get when you're on the job that could be 3 pages long, single spaced.
Yeah.
And there's all this medical terminology in there and things, and you're like, you got to
Yes,
read it.
and I thought about that, and the idea just seems so overwhelming.
Mm-hmm. Mm-hmm. It's a lot. It is overwhelming. But when you use your finger, all of a sudden it's one word at a time. You will increase your comprehension, understanding what you're reading, and you'll be able to go through it more quickly. And speaking of Spencer Reed, if you watch him in those scenes where he's reading lots of things, right? Like he'll go through a book, you
He
watch,
points.
he does, he points. You think he's not really pointing because he's going so fast, but when you practice this often enough, you'll be able to move through the words that much faster and that much easier. But more important, you will understand what you're reading.
And that actually makes sense because like with reading comprehension and stuff on those standardized testing, I was always good at getting through it quick because I used my finger and was able to find what I needed without having to read the whole entire paragraph.
See, you're
So
smart.
it does make sense.
Okay. Well, we just got to bring that habit back. And it's
Mhm.
really going to help you. Okay. So that plus the medical dictionary and query when necessary. That's another thing that's a little complicated for adults to do because so often we have been conditioned to
Not
only stupid people ask questions. But let me tell you this is not only is it smart because when you ask if you're unsure, you get an answer and then you can code it with confidence, then you know what is right. But the other part is it is actually part of your legal responsibility as a coder to query when necessary.
yeah.
And
And of course, if I don't understand, I'm definitely gonna query and find out. Can you further explain this to me because I do not want to be held accountable for miscoding.
exactly. And you will be held accountable because it's going to be your job.
Yep.
So
And
let's be
signature
held
will be on it.
accountable for accuracy.
Exactly.
Courtney, 100% accurate. Yay.
Yeah. And it's in the same rule applied in nursing. If it wasn't documented, then it wasn't done.
Exactly. But sometimes the documentation can be insufficient. There may be words missing. Okay. It may contradict itself. I have seen physician documentation where in one sentence it said the patient has a hole in the right tympanic membrane.
Okay.
So I glued the left tympanic membrane to seal up the hole.
Do what?
Exactly. Exactly. So you got to ask
Are
the
you
doctor.
sure did you mean to put that?
Okay, so like which just you only have a choice of 1 out of 2, okay? Which
Yeah. So yeah, and in probability, what happened was he was tired, long day, jumbled
but
up his words.
still
Where's
we
mine?
can come up with a thousand different excuses, but the bottom line is your code has to be correct.
Yeah. Okay.
The code stops here. You know the old saying, the buck stops here, the code stops here. And you have to say, okay, go in and correct this so I have the documentation to support the correct code.
Okay.
We're a team together with the physicians.
Yeah.
Okay.
That makes sense.
Right. And so and you're right, is I'm tired. I had 3 other patients waiting, people screaming at me. We all understand stress. Do you understand
Oh,
stress? Have you ever had
oh,
stress? Right.
oh
Yes.
yeah. Every
Human.
day.
Right. Every now and then I have a student point out to me that I made a mistake, and I'll do like this is like human. See, human.
Yeah.
Human.
Yeah.
Okay. And thank you for telling me so I can fix it. All right.
Yeah.
Right. Because I do really, really appreciate that. But that's the point is you must make certain that what you're doing is accurate. And if the documentation cannot get you there, you have to ask for it. And I just like to reinforce the fact that this is not optional. This is part of your job as set forth by the federal government.
Yeah.
Okay.
I
So,
was gonna ask you, is there any kind of like maybe some cases or paperwork or something that I can maybe work on
okay,
and
you have the
just
Let's
kind of
Code It
see,
book.
like send it to you and be like, okay, this is what I thought, and then maybe you could point out like maybe what I did wrong. Just
Sure.
so I can
Did
kind
you
of
go
start.
did you go through last week's live lecture when we went over the obstetrics
I
cases?
did. I
Okay.
did. I did
All
go
right.
over that. I've gone over all of them that I wasn't able to attend to. And I have gone through those.
Did that
And
help?
like I said, they did help. And what's happening is, like I said, I am confusing myself. The obstetrics unit wasn't hard for me, but when it came to that case, and I did it, and at the end of it, it was like, how did I mess up? And then that
Well,
happened this past week when I did the three new technology and all that,
mhm.
which I know I'm way ahead. I kick myself for that, but it is what it is.
That's
I'm
very true.
just wanting to make sure that before finals that I have a clear vision, that I am able to point and understand and be able to get it correct.
I want that too.
Yeah.
Okay. So, let me think. I can send you some case studies. You went through the chapter reviews in the book.
I have.
Okay. I can send you some more case studies
Okay.
and have you go through them. And then all I ask is, as you go, after you code them and you go back and you see you got this code correctly and this code not so much, if you can't figure, and this is your job, is you need to figure out where you went wrong,
Yeah.
because that's how you learn.
Mhm.
I mean, I can tell you, yes, this should have been an open approach instead of percutaneous approach. And then you'll go, oh, yeah, I see that, but
Yeah,
that's not in your
I
brain.
need to point it out.
Right.
I
You
need
need to,
to.
right. And then make sure you ask me specific questions if you can't figure it out.
Okay.
Okay.
And I think then there was one, I don't know why I did it. Maybe because I'm in coding one at the same time, but for some reason I grabbed both books. I do not know why.
Well, you're getting ready prematurely. You're getting ready for HIM250, which is the capstone, where you will be coding diagnosis and procedure at the same time in the same cases. So that's good. And just focus on, remember, ask yourself the question, why does this patient need this physician's care? That equals the diagnosis code. Okay.
Okay.
What did the doctor do for the patient or to the patient? That's your procedure code.
Okay. All right. That makes sense.
Okay.
All right. Thank you so much.
You're very welcome. My pleasure. My real pleasure. I'm glad you were able to join us today. And I, I I just want you to understand that the best way, and all my experience tells me this, the best way for you to learn is for you to do, for you to go back and analyze what you did, especially the stuff you did wrong. Okay. And then ask for the stuff where you go, okay, or even, and there may be times where you'll go, I got that correctly, but I don't really know why. I mean, that can happen. That can happen too. All right. And that's how we build your understanding, and that's the part in your brain.
I
Okay.
know from start to now, it makes more sense than it did in the beginning.
Oh, good. And we still have 4 more weeks of trying to make more sense. So it's,
Yeah,
and
and I did have coding beginners coding back in 2005. So I mean, seeing the codes wasn't brand new to me. And I knew right
Well,
away I was gonna have a problem
it
with
would be
it.
pretty much new because in 2015, we totally changed the code sets.
Yeah, I noticed that. And the neoplasm table is so much better, but it's
Yes.
a very complicated part.
Yes, that is true.
So,
All right. Well, I am
I will go back
here.
and I will review everything that I've done up to this point and what you send me. And I will start utilizing my finger and trying to figure out on my own from start to finish.
Good. And remember, you might feel rushed because you have so much on your plate, but everybody has a lot on their plate. But the point is you have to be slow and steady wins the race. Seriously. In coding, it's so complicated. Slow and steady wins the race. Use your code books because they will tell you if you're missing any information. Okay. And just remember why the patient needs the care, diagnosis, what was done for the patient, procedure.
Okay.
Okay.
Will do. I appreciate this today. As I was
My
feeling a
pleasure.
little deflated. You've made me
Good.
feel a lot better about
You
it.
can do it. You could do it. You could do it.
I'm gonna do it.
Yes, you will.
All
Yes, you will.
right.
Okay. Bye.